now let me invite our colleague from the Department of Pediatrics, Małgorzata Wojcik, who will cover the issue of mitochondrial diabetes. The floor is yours.
Thank you. Dear committee, dear colleagues, I would like to present you a case of maternally inherited diabetes and deafness. The beginning of the story is completely unusual, not only as for rare types of diabetes, but for any type of diabetes. Almost 16-year-old girl was admitted to the emergency department after a car crash. On admission, she presented with vomits, headache, chest pain, and dyspnea. Her severe condition caused the admission to intensive care unit, and she presented with increased breath rate, heart rate, dehydration, and suffered from abdominal pain and what was surprising, valvular mycosis. At first, the doctors thought that her bad condition was caused by multi-organ injury or head injury, and even CT scan showed subanechoic bleeding without need of surgical treatment at the moment. But what was very surprising, look at the results of the blood test. She had hyperglycemia with ketonuria and glucosuria and diabetic ketoacidosis at the moment. The details of the story, of the family story, show that she was the first child of a diabetic mother. Her mother had been diagnosed with type 1 diabetes at the age of 35 and was treated with insulin. The additional information was that she also suffered from hypoacusis. The development of the child was completely normal. The family tree shows that mother and the girl were not only people with diabetes in the family, but they were only one that were available to attend the study. And in both of them, the genetic testing revealed the mutation in mitochondrial DNA, which is connected with maternal inherited diabetes and deafness. This is a very small point mutation. I'm not a specialist in medical genetics, I'm just a clinician, so I would like to show you as clinician to clinicians. The small point mutation, the only one substitution in the tRNA may cause a very huge damage in the body of the human. Why? One of the hypotheses show that it promotes the formation of the dimer structure, and that leads to the loss of function. And the ATP the production of ATP in the body cells is decreased. According to the pancreas beta cells, we have decrease in insulin production. What is very interesting, the point mutation may cause not only maternally inherited diabetes and deafness, but may be also present in patients with completely different clinical condition, which is called mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes, very serious condition. And what was recently described with less serious condition, progressive non-diabetic kidney disease with deafness without diabetes. Why we have such a wide spectrum of the clinical symptoms caused by only one single mutation in the mitochondrial DNA, and why within the same family we may have different phenotypes. This is connected with the features of maternally inherited diseases, with mitochondrial diseases. If we imagine that we have the red dots with the mutated mitochondrial DNA, and the blue spots, it's a wild type, the normal mitochondrial DNA, the distribution in the body cells may be different. The transmission to the oocyte may also be different, and the distribution in the tissues, in the body tissues of the child is also different. That's why we may have different manifestation in different persons within the same family. And that's why the diagnosis of mitochondrial diabetes and deafness according only to clinical manifestation is very, very hard. Let's go back to our patient. At first, she was diagnosed as type 1 diabetes because she was relatively young. She was 16-year-old, presented with typical signs of diabetes, and was insulin dependent from the beginning. What was interesting, apart from her mother's story, her metabolic control was quite well in spite of completely lack of compliance. The time when we diagnose mitochondrial inherited diabetes and deafness may be different. Usually we have young adult persons, but it may be also present in teenagers. Some hypotheses say that maternally diabetes during pregnancy may promote the earlier beginning of the symptoms in the child. Probably it was in our case. Our patient was diagnosed with DKA. As you can see, only half of the patients with MIDD are diagnosed due to clinical symptoms. Half of them is diagnosed due to family history as the routine screening. Our patient presented with the subphenotype called pseudotype 1 MIDD. Some authors suggest that we should divide MIDD into subtype 1 and subtype 2. The differences according to the symptoms are only related to the age of the diagnosis and to the time of manifestation of the leading symptoms.